Hello everyone. Today we'll discuss about the nephrotic syndrome and its case presentation. Here we'll discuss about what are the leading questions or how you're going to present the case when you get nephrotic syndrome in your examination and the possible viva questions that can be asked to you. Okay. So first starting with the how you're going to present. First child name. Next is age, sex. Next you have to write whether the child is first born, second or third born of consanguineous marriage or non-consanguineous marriage, coming from which place. Next, brought by whom. Mostly it will be brought by mother or any grandmother or father whose reliability is good. Okay, this is the starting. From this, what are the possible questions that can be asked in your viva? Okay, the possible questions can be according to the age. Okay, so what is the most common age group of presentation of nephrotic syndrome? So question, age. Most common age group of nephrotic syndrome is between 2 to 6 years of age. How will you classify nephrotic syndrome according to the age group? So you can call congenital nephrotic syndrome. So first is congenital nephrotic syndrome when the onset is at birth or within 3 months of birth. Okay, that is congenital nephrotic syndrome. Second will be infantile nephrotic syndrome. That is when the child's onset of nephrotic syndrome is between more than 3 months to 1 year of age. It is infantile nephrotic syndrome. Third, childhood nephrotic syndrome is our most common age group, that is between 2 to 6 years of age. The uncommon age group of presentations are when the onset is less than 1 year of age or more than 10 years of age. Here you can face the complications of nephrotic syndrome, or the child can present with hypertension, with hematuria. So these kind of things you have to think about nephrotic syndrome with other complications. Okay, in that age group. Next, if you tell about this answer, next question will be, how will you classify congenital nephrotic syndrome, or what do you know about congenital nephrotic syndrome? Okay, so in congenital nephrotic syndrome, it is two types. One is primary, another one is secondary. This primary is mostly inherited form. It is inherited as autosomal recessive form. They have poor prognosis. Okay, so when you tell the primary congenital nephrotic syndrome is inherited as autosomal recessive, next you have to tell, they will be asking what are the genes that can be involved here. So mutations in genes. So the genes that can be involved are NPHS1, NPHS2, LAMB2 and WT1 gene. Okay, next will be, what are the syndromes associated with these genes? The syndrome associated with first one, NPHS1 and NPHS2, is Finnish type congenital nephrotic syndrome. Okay, this NPHS1 and NPHS2 encode for the proteins such as nephrin and podocin. Next, the syndrome associated with LAMB2 is Pearson syndrome. So what are the components of Pearson syndrome? Or the question will be like, what are the other features the child can have other than congenital nephrotic syndrome in Pearson syndrome? Here, this LAMB2 gene encodes for beta-laminin 2 protein. This is a critical for the basement membrane of glomerulus and the ocular basement membrane, this beta-2 laminin. Okay, so the child can present with congenital nephrotic syndrome plus bilateral microchoria. Okay, this is the features of Pearson syndrome. Okay, next will be the syndrome associated with WT1 gene. Everybody knows it is Dennis-Dash syndrome. So what are the other features of Dennis-Dash syndrome other than this nephrotic syndrome? The child can present with ambiguous genitalia, and second will be Wilms tumor. Third will be progressive renal insufficiency, and fourth will be early onset nephrotic syndrome. Okay. So these are the features of Danish-Dash syndrome. Okay, this can be the questions from this. Next you will be writing the chief complaints. So the child presenting with the chief complaints of, you have to write it in the patient's own word and also in the chronological order. Swelling of both the eyes for how many days? Next, swelling of abdomen if present, or swelling of both feet for how many days, and with decreased urine output for how many days. Okay, this will be the chief complaints. Next will be your history of presenting illness. In history of presenting illness, you have to elaborate your chief complaints. Here mainly you have to keep in your mind, in history of presenting illness, you have to write about 3 C's. That is course of the disease, causes for the disease, and complication of their particular disease. So the questions will be pertaining only to these 3 C's. Okay. So you have to start with history of, or the child was apparently normal 1 week back, then presented with the swelling around both the eyes, which was insidious in onset. This is insidious in onset. So the classical finding of nephrotic syndrome will be the periorbital swelling or periorbital puffiness will be more in the morning after waking up, and it decreases as the day progresses. So you have to mention that. So it was more in morning on waking up and decreased as the day progressed. Okay, so this will be your first history. Second will be history of swelling of both the feet. You will write about the onset, which was again insidious in onset, and their progression, whether it progressed till knees or progressed till thighs, whether it was associated with scrotal swelling or not. Okay. Next, history of decreased urine output for how many days? For 1 day. For example, this is for example, for 1 day you're writing. You have to write like, how did you ask about history of decreased urine output? So you have to write in the form of passing once or twice per day while the child was normal days. So while the child during normal days had frequency of about 4 times per day. Okay, so by this I elicited the history of decreased urine output. Okay, in this way you can compensate, or you can justify your answer of decreased urine output. So from this, what are the questions can be asked? So questions, possible viva questions from these history. First, what is your probable diagnosis from these 3 history? So you should not straight away tell it is a nephrotic syndrome. So you should tell that it can be due to some disease pertaining to renal origin. So why are you telling us renal origin will be your next question? Because in renal origin, initially the swelling will be as a periorbital swelling, then it can progress to abdomen, then it can progress to both the feet. Supposing if it is a congestive cardiac, second question, if it is a congestive cardiac failure, where the swelling can be present. The swelling or the edema starts in the dependent regions. Okay. So you have to tell it as dependent regions, because in pediatric, if it is a infant, you have to tell the dependent regions only. What are the dependent regions? You have to tell sacral edema or neck swelling. You can't straight away tell pedal edema. Okay, only the child who walks, you can tell it as pedal edema. So this swelling starts in the from the leg, then it progresses to the abdomen, then it progresses to facial puffiness. Third, suppose if the child has a this chronic liver disease, where the swelling can start from. So the edema starts from the abdomen. So there will be an abdomen distension in this child. Okay, so these are the possible questions. Next will be, what are the causes of, fourth question, causes of generalized swelling. Okay, first will be cardiac disease, that is congestive cardiac failure. Second, disease pertaining to renal origin. Disease pertaining to liver. Fourth will be hypothyroidism. In a child with hypothyroidism, the child can have the presentation of mixed edema and can have a generalized swelling. Fifth, when the child presents have anemia, the child can go for congestive cardiac failure and have generalized swelling. Next, when the child have a protein losing enteropathy, the child can have generalized swelling. Seventh, when the child have a severe protein energy malnutrition, that is a SAM child. In SAM you can have whether kwashiorkor can be present or there can be marasmus. In kwashiorkor the child will have a generalized swelling, plus along with this the child will have both skin and hair changes. So you can find it out with that, or we can find it out with the history. Okay. Eighth can be anaphylaxis. Okay, so these are the some causes for a generalized swelling. Okay, next, if suppose there is a generalized swelling, what is the term you use? We use the term called anasarca. So what is the meaning of anasarca? What is anasarca? So when the child has a present with a generalized swelling, along with that there should be an involvement of two serous cavity. So two serous cavity is either the child can have pleural effusion with ascites or bilateral pleural effusion with pericardial effusion. So then there is an involvement of two, there should be an involvement of two serous cavity with generalized swelling, then you call it as anasarca. Okay, this is the questions related pertaining to the swelling. Next question can be pertaining to the urine output. So what is the normal urine output in a child with 1 year of age group or 1 to 2 years of age group? So in a 2-year child, so what will be the urine output, normal urine output? So it can be between 3 ml per kg per hour. Okay, in supposing if it is a preschool or a school going children, preschool or a school going child, what is the urine output? It can be between 2 ml per kg per hour. When you call it as oliguria. So when the urine output is less than 0.5 ml per kg per hour for at least 6 hours, then you call it as oliguria. When you call it as anuria, when the child does not pass urine, it is not voided urine for 12 hours, the child has not voided urine for 12 hours, or when the urine output is less than 0.3 ml per kg per hour for about 6 hours, then you call it as anuria. When you call it as polyuria, when the urine output is more than 4 ml per kg per hour, then you call it as polyuria. Okay, these can be the questions for this. Next. So, next can be, we have talked about the swelling here. Among the renal origin, what are the causes for, among this renal origin, what are the causes for this swelling when the child presents with the swelling? So, I'll write it here. So, among renal origin, what are the diseases that can present with swelling? It can, one is nephrotic, other can be this post-infectious glomerulonephritis, they can present with swelling. Next can be AKA, The AKA, simple AKA can present with swelling. When the child has a severe urinary tract infection, then the child going in for AKA, the child can present with fluid overload. And sometimes the child with this chronic kidney disease will also present with the swelling. Okay. Next, supposing if in this child we have not mentioned about any breathlessness. Supposing if you are going to mention about the breathlessness in the history, what are the questions? So what are the causes of breathlessness in this child, in nephrotic syndrome or in nephrotic syndrome? Because your histories, everything is pertaining to nephrotic syndrome. What are the cause of breathlessness in a child with nephrotic syndrome? One can be massive ascites. Second, bilateral pleural effusion. Third, it can be pneumonia, because infection is the most common complication of nephrotic syndrome. So the child can present with pneumonia, or it can be due to pulmonary embolism. Okay, these are the causes for breathlessness. Next, what are the negative history, that is cause? Now we have finished about the course of the disease. Next we are going for the cause for the swelling and decreased urine output. So next history will be no history of cola colored urine or red colored urine. So what is the cause for this cola colored urine will be the next. So the cause will be post-infectious glomerular nephritis. You can have this cola colored urine. So why in the glomerular nephritis you get a cola colored urine? It is because of the hematin that is produced in the tubule, that is giving the urine an appearance of cola color, because of hematin. Next, what are the causes of red urine, that is hematuria? So the causes can be cystitis, that is lower urinary tract infection, urethritis, cystitis, or it can be physiological, or it can be due to hemoglobinuria, it can be myoglobinuria. Okay, so these are the causes of your hematuria. Okay, so this is the first negative history you are going to tell. Next will be no history of sore throat, skin lesions prior to onset of illness. Okay, so for you to tell us as a sore throat, how will you define a sore throat in a child, or why are you telling this history? So this history is, again, it is told to exclude this post-infectious glomerular nephritis. So this sore throat, how we are going to tell the child is having sore throat? What are the histories you are going to put forth to the mother to elicit a sore throat? So the child should have a fever, pharyngeal hyperemia with lymph node enlargement. Then you call this child as having a sore throat. Okay. So what will be the treatment if a child has a sore throat like this? The treatment will be the drug of choice. The drug of choice will be amoxicillin. How many days you will give for sore throat? It will be 10 to 14 days. Okay. Next. So this is about the sore throat. You have finished. Next is the skin lesion. So what is a skin lesion you are expecting when you ask pertaining to this question? It is impetigo. Okay. So this impetigo can also precipitate post-infectious glomerular nephritis. So what is the management for this impetigo? Again, the treatment for impetigo. So it depends. If it is a simple impetigo, you give a mupirocin ointment, that is topical antibiotic. Suppose if the impetigo involves face, that is around the nose, that is dangerous area of face, nose and mouth, then you will be giving a systemic antibiotics. So what is the drug of choice for the systemic antibiotics? It is oral cephalexin. Okay, then you give a what is it called, systemic antibiotic. There is indication for systemic antibiotic. So these can be the possible questions that can be asked. Next, what is the negative history? Next will be, you have excluded glomerular nephritis and post-infectious glomerular nephritis. Third will be no history of increased precordial activity or fast breathing. For what you have asked this question? To rule out cardiac disease. Okay. Fourth, no history of yellowish discoloration of eyes or bleeding manifestations. So this is done to ask, or this is asked to rule out liver pathology. So what kind of bleeding manifestations you can expect? You can expect mainly the so-called upper GI bleeding. So upper GI bleeding like hematemesis and melena. Okay. Next, no history of any insect bite. So why you ask this insect bite? One, it can be to rule out this anaphylaxis. Okay. So one is to rule out anaphylaxis history. Next, this bee sting. So which insect they can ask? Which insect that can precipitate nephrotic syndrome? Bee sting can precipitate nephrotic syndrome, and even snake bite can precipitate this nephrotic syndrome, or it can be a secondary cause of this nephrotic syndrome. Okay. Next, sixth will be no history of drug intake. So in drug intake, what are the drugs that can produce proteinuria? So the drugs, next will be drugs that can produce proteinuria. Your answers will be, one is penicillamine. This penicillamine is given for the treatment of Wilson's disease. So this can have D-penicillamine. This can have proteinuria. ACE inhibitors like captopril. Your anti-epileptics. Fourth will be NSAIDs. NSAIDs is a nephrotoxic drugs. So this I asked the histories for this drug intake. Okay. Next, seventh, pertaining to hypothyroidism, you will be having no history of constipation or lethargy in the child. This is to rule out hypothyroidism, because the child with mixed edema can present with the swelling, for to rule out that. Eighth, history of loose stools, skin and hair changes. This is to rule out this protein losing enteropathy and protein energy malnutrition. Fine. So loose stool with nephrotic syndrome. Suppose the child is having nephrotic syndrome with loose stools. What it can precipitate? It can precipitate thrombosis in this child. Okay. So these are the next will be no history of blood transfusions. Why blood transfusion? Because supposing if blood transfusion, hepatitis B and C can be involved. This Hep B and Hep C can cause secondary nephrotic syndrome. Okay. Next will be, this is about the causes. You have found out the cause. And another one cause. Sorry, I left. History of, no history of burning micturition. Because UTI can also present with facial puffiness, bilateral pedal edema. You can present because they can have a short course of AKA and they can present with these symptoms. Okay. Next, no history of fever, skin rash. So what is the skin rash you will expect in this? The skin rash you can expect in a child with swelling. For what you have asked this question will be palpable purpura. 1. In which case you will have palpable purpura. In the child with henoch-scleran purpura, you will have this. In henoch-scleran purpura, where this skin rash will be present, mostly in the lower extremities, that is in the dependent region, you will have this. So to rule out the HSP, I have asked this question. One can be this, another can be malar rash, because a child with SLE can also be a cause of secondary nephrotic syndrome. So to rule out that, I have asked this question. Okay, that's it. Next you are going, so I have found out this 11 questions you asked about the causes. So course you have finished, cause you have finished. Next you are going for complications. That is, first one is no history of breathing difficulty, abdominal pain, vomiting. So for what you have asked this? Mainly one is, main complication is spontaneous bacterial peritonitis. To rule out spontaneous bacterial peritonitis. Next most common is hypovolemia. The child will have all the bilateral pedal edema with massive ascites, but the child can present with abdominal pain. When the child presents with abdominal pain with this swelling, the child will have hypovolemia that can even cause this abdominal pain. Okay, wow. Next question. This is complications. Okay. Next will be no history of headache, blurring of vision, and seizures. This is asked to rule out the complications like PRES. PRES is posterior reversible encephalitis syndrome. It will be mainly present in a child with glomerulonephritis, that too mainly post-infectious glomerulonephritis. Then thrombosis. Okay. Next, what is the treatment of PRES? PRES is when the child will have posterior reversible encephalitis syndrome, mainly because of increase in the BP, the blood pressure. That is because of hypertension. So what will be the treatment for this? Can you give a oral nifedipine or sublingual nifedipine? Oral nifedipine is preferred in this child. Sublingual is not preferred. Why? Because sublingual will have a erratic absorption in the child. So now we are giving a oral nifedipine because it will be a short acting. Supposing if you can't give a oral nifedipine, if the BP is very high, that is more than 95th percentile, then you will start with the IV labetalol. You can start. Okay, this is about the history of present illness. Understood? Shall we go? Okay. Tomorrow we'll talk about, and next video I'll cover about the past history, vaccine.